Unit 10, The Roles and Responsibilities of a Healthcare Worker by Emma Moore. The area of healthcare that I have chosen to discuss during this presentation is occupational therapy. And during the presentation, I will explain what is occupational therapy and discuss the recent changes to the roles and responsibilities of an occupational therapist and the impact that these changes have had. I will talk about the role that professional bodies perform for occupational therapists, and I will talk about the effectiveness of the multidisciplinary approach in the occupational therapy sector. Let's begin the presentation by discussing what is occupational therapy. So an occupation is something that you spend time doing either for pleasure or because it needs to be done, and we have a variety of occupations such as cooking dinner, working, meeting friends, getting dressed, driving the car, playing tennis, hoovering and eating. However, in life there are times when we can no longer complete these everyday life skills, perhaps due to accidents, illness or disabilities, and this is where an occupational therapist steps in. So an occupational therapist works in a variety of sectors, from education settings, independent living arrangements, care homes and hospitals, and they work with a range of people from mental health patients to elderly people. The role of an occupational therapist is to help a person live as independently as possible. This could be by adapting homes and installing equipment, for example bath and toilet aids, specialist seating, handrails or stair lifts, reteaching everyday life skills after an injury or stroke, and adapting life after surgery. For example, learning to use muscles that have deteriorated, or amputees helping to walk more independently. So that is the role of an occupational therapist. So let's talk about the changes to these roles and the responsibilities of occupational therapists. The most recent change that we have seen to the healthcare sector in the past years is the COVID-19 pandemic. And the Royal College of OT carried out a survey to see how these changes have affected the occupational therapy sector. In this picture we can see some of the figures. So due to staff sickness and shielding across the health sector, many people were redeployed not only to take on new roles in occupational therapy, but to other multidisciplinary teams, including the ICU units. Some workers were seen to come out of retirement to rejoin the workforce to help dwindle in numbers, and some Band 3 workers were being placed as Band 5 on the HCPC temporary register. HCPC stands for the Health and Care Professionals Council, and we'll discuss this later in the presentation. People were seen to have increased time working, not retiring as planned, and working increased hours. All changes have limitations and positives. The limitations of these changes to the workforce are that due to staff shortage, patients were not able to be seen or not being referred altogether. This meant long waiting lists were being created. People had to very quickly learn new skills and often pick up from where another professional had left off. This can be seen as a positive, as it meant workers learning new skills and new job roles. This gives people wider opportunities and wider career options. Closure to workplaces or study meant people using remote learning from home. People had to very quickly learn new IT skills for remote learning. However, the positive side of this is that working from home meant that patients were able to be seen remotely, more appointments could be covered as it would cancel out travel time. However, for education, this meant students studying occupational therapy degree could not carry out work placements. People not being in work settings had to see a reduction in routine caseloads and referrals. Some patients were seeing different groups of people, and some referrals put on hold altogether. This again means long waiting lists. People not being referred to occupational therapy means people's quality of independent living is affected negatively. However, non-referrals meant occupational therapists can get through a referral list, the referral list that they currently would have. So, as I discussed on the last slide, the impact of COVID-19 in the occupational therapy sector. So we discuss new opportunities, wider roles, learning new skills, new career paths, and home working and online meant less travel. We discuss the negative impacts, which were financial loss, patient waiting lists, no occupational therapy in education, training cancelled or put on hold, and personal health and well-being was massively affected for patients and the working occupational therapists. So what other changes to the roles and responsibilities of the occupational therapists have we seen? So commonly, occupational therapists help people adapt to different lifestyles following an accident or stroke or people suffering with dementia. However, the role is evolving and expertise are being used in different ways. Occupational therapists are being called upon to help with areas such as anxiety or stress and depression. And there have been a great amount of referrals from the mental health sector. This is positive, as it means more job roles and a wider skill set being taught. However, funding is needed for training, and the bigger the patient lists, the bigger the funding will be needed to complete these lists and to employ new occupational therapists. The next part of this presentation is going to be about the professional body and how they affect occupational therapy. So, a professional body is an organisation with individual members practising a profession or an occupation in which the organisation maintains an oversight of knowledge, skills, conduct and practice of that profession or occupation. This image shows all of the professional bodies within the healthcare sector. The one that we are going to discuss is the HCPC, which is the Health Care and Professionals Council. So, the professional body that oversees occupational therapy is the Health and Care Professionals Council. The role of the HCPC is to register qualified occupational therapists. Once you have qualified as an occupational therapist, it is actually an illegal offence to practice or see patients without being registered with a professional council. And to be registered, you must meet the standards set by the HCPC, which are found on the HCPC website. Once you are registered, you can then use the title of an occupational therapist. The HCPC keeps a list of each person registering their training, the professional skills, the behaviour and the health of the registered occupational therapists. Audits are carried out on a yearly basis. These audits are carried out at random and occupational therapists are picked out at random. So a summary of the role of a professional body would be to register the occupational therapists. To register an individual must meet the standards set by the HCPC. The HCPC monitors training, professional skills, behaviour and health, and auditing is carried out yearly and at random. The next part of our presentation is going to be on the multidisciplinary approach. A multidisciplinary team is a group of professionals that work around one patient. For example, a child with autism may see their family GP, an occupational therapist, a speech and language therapist, their teacher, an education psychologist, and in some cases a dietitian. So that's a lot of professional people working with one patient. And each professional brings their own expertise and provides their service to the patient to give the best outcome and care. The team will devise a care plan, and often the patient will be given a care worker who will be the main point of call and will collaborate the information from each professional. Occupational therapy, when used as part of a multidisciplinary approach, means patients can see a professional within their living arrangements, instead of long hospital stays during rehabilitation periods. This can help to relieve some pressure in hospitals and can help with funding costs. A person with dementia is usually admitted to hospital when they can no longer live independently. An occupational therapist will join the doctors and other professionals caring for the patient with dementia, and they will carry out assessments to see if the patient needs to go into a care home or will be needing to stay in the hospital. An occupational therapist may work closely with the GP when it comes to a patient suffering from chronic pain. The occupational therapist and the GP will work closely together to find the best activities to help physically and the medication to coincide with these activities. The positives of this approach are the patient will be getting a wide variety of expertise and the best treatment possible, so recovery time can be shortened. If a patient is waiting for a referral, having a large team of experts can speed up a referral and get the process approved without delays trying to find professionals to sign paperwork. The patient may also get treatment quicker for this same reason. A patient with multidisciplinary team will be able to access resources from a variety of departments. These resources can be combined together, providing immediate care where necessary. A patient can set their own goals with a multidisciplinary team, and they can work with each professional on these goals, and this has seen inpatients' time reduced. The negative of a multidisciplinary team can be that each professional must take the time to finish their own work whilst putting aside time to collaborate with the rest of the team. They must respond to the care plan, even if it is not all that is stated on the plan refers to their particular area. Having a large team means different backgrounds come to play. This can be that some of the team may be more educated than others, and people work to a different schedule, seeing meetings difficult to arrange. The team must also know what each professional specifically does, so there is no confusions. If everyone is not on the same page, the communication will be weak and the patient's recovery will be prolonged. Individuals' needs may then not be met. Funding can also be an issue. Finding the funding for one patient to have a team of people working with them can be a challenge, especially in the current climate of the NHS. If the team of professionals in a multidisciplinary team approach can be well organised and communicate professionally, great things can happen for patients. So, a summary of the positives and negatives of the multidisciplinary approach: a wide range of experts working with one patient, faster referrals, wider access to resources and departments, patients set their own goals. And the negatives: a larger workload, different educations and backgrounds, professional statuses, funding, and organisation skills. And a recap on the multidisciplinary approach in occupational therapy. Occupational therapy reduces the pressure on hospitals when working as a multidisciplinary team. I hope the information I have relayed in this presentation has been useful and well received. Thank you for taking the time to listen.